Hello, everyone, and good day. My name is Mike Hamilton. I'm Medical Director at ISNP Canada. Welcome to the spring edition of the Med Safety Exchange. It's a lovely day in the Greater Toronto Area. I hope it is the same for you. Thanks very much for joining us today. We know it's busy. We know you're out there doing good work, and we really appreciate you spending some time with us. Today I nominate Wednesday, May 27th, and as we settle in, I'll ask our Brock University student Larian to perform the land acknowledgement and to go through a few introductory items. Larian?
Great, thank you. We begin with a land acknowledgement for our office in Toronto, and I encourage you to reflect upon where you work and reside. We acknowledge we are hosted on the lands of the Mississaugas of the Anishinaabe, the Haudenosaunee Confederacy, and the Wendat. We also recognize the enduring presence of all First Nations, Métis, and Inuit peoples. We are grateful to live, work, and play on this land, and we want to contribute to the implementation of the Truth and Reconciliation Commission's 8 health-related calls to action. This webinar is a production of ISNP Canada and the Canadian Medication Incident Reporting and Prevention System, CMIRPS, with contributions from all of our partners in medication safety and you, the audience. For confidentiality and participation purposes, we ask that no AI bots or automated assistants be present during this meeting. A recording of this webinar will be available in the near future on our website. The Med Safety Exchange is presented on the Zoom webinar platform. Audience members are automatically muted and your video is disabled. The presentation part of this webinar is being recorded and will be available on our website. There are a few ways to make comments or to submit questions. You can find the Zoom toolbar typically at the bottom of your screen. The chat panel is open for the broadcast, so feel free to introduce yourself and tell us where you're from. You can also make comments and ask questions via chat. All chat entries will be visible to the audience. If you select the Q&A tool, a window will open up. You have the option to submit anonymously if you wish by checking off the lower box, and questions will only appear in the panel once they're answered. We'll try to get to as many questions as we can, and there will be an evaluation poll at the end of the session, and we encourage you to provide feedback. Now back to Dr. Hamilton for an overview of today's session.
Thanks very much, Larian, and again, thank you for joining us today. We have a really good show that touches a lot of topics that a lot of which address the safety infrastructure we have in Canada. Lookalike packaging and labeling, it's something that ISNP Canada has dealt with for years. We've all dealt with this as clinicians, even as consumers, families, and caregivers. It contributes to errors both here in Canada and around the world. And we're going to welcome our colleagues at Health Canada to feature a number of recent concerns related to lookalikes and provide some further insight on what could be done at a regulatory level to minimize these risks of these types of errors and to make it easier for clinicians to select the intended drug. And we'll follow that up with the recognition that reporting and learning systems are ever evolving. There are a wide range of topics, a wide range of perspectives, many approaches and tools we use when developing these reporting and learning systems, particularly the learning part. All sectors, all disciplines, all roles play a role or play a part in delivering safer care. And what we're going to hear from Health Canada is in large part due to the reporting and learning systems we have, both here at ISNP Canada, at CMIRPS, and as well through adverse event reporting at Health Canada. So we'll hear a little bit about the NIDR, the NSIR, the NSIR, and how it works to enhance medication safety and what they can tell us about the landscape of where vulnerabilities exist and how practitioners and organizations can contribute to learning. And finally, we'll see how a lot of this various information comes together in an excellent learning and assessment tool, the updated MSSA for hospitals. So packaging and labeling is one of the first interactions a clinician has with the drug. it plays a large part in the selection process. We rely on color, we rely on shape, the appearance, printed words, and other characteristic visible items as we judge whether or not we're selecting or handling the intended medication. These characteristics are one of the key initial roles in the differentiation and discrimination of one drug from another. And because of that, when packaging and labeling of one drug is similar to another, we introduce a big risk of misselection with all the predictable downstream effects. Now, we welcome our great friends at Health Canada to further explore this topic. So welcome, and allow me to hand over slide control to you. And that should be great. Thanks very much.
Mike. Good afternoon, everyone. My name is Sally Pepper. I am a pharmacist working with Health Canada, and Health Canada is a partner with ISMP Canada in the Canadian Medication Incident and Reporting System, also known as CMIRPS. And this afternoon, I'm going to share a few different examples of lookalike issues with medications to highlight Health Canada's activities on this topic. As part of Health Canada's responsibilities in the approval of new drugs for the Canadian market, we review and approve brand names, product labels, and the outer packaging. We review and approve product monographs and any information that accompanies the drug, such as package inserts or instructions for use. Our role is to ensure that these elements support safe use and don't present a risk for medication errors. Of course, in some instances, it can be difficult to predict the ways in which end users will interact with the product and the labeling, and problems may not become apparent until after the drug is marketed. At that point, we may receive notifications from health professionals or patients identifying a safety concern. Information reported to ISMP Canada through the Canadian Medication Incident Reporting and Prevention System that identifies problems with manufacturer naming, packaging, and labeling is also shared with Health Canada. We take into consideration the evidence and the knowledge generated through medication error reporting when working with the pharmaceutical industry to address safety concerns. Your reports are important to us, and they help inform decision-making. Did I advance the slide? No, here we go. Lookalike labeling and packaging is really, it's a difficult problem to address because it's a moving target. It's a moving target due to new medications on the market, changes in labeling or packaging from manufacturers, revisions to formularies, and of course, drug shortages. These situations can be disruptive, and they result in changes to the appearance of medications, which introduce new risks for selection errors and other medication errors, such as dosing errors. On this slide, you see a snapshot of different publications, including advisories from Health Canada, that alert health professionals to risks with lookalike situations. In 2024, following a shortage in Canada of cisatracurium, Health Canada authorized the import of the drug from Italy. The drug was supplied in a clear glass ampule, not in a vial, as per the usual Canadian supply, and also without the warning stating paralyzing agent that we ask Canadian manufacturers to add to the top of the cap and the ferrule. There were other safety requirements that we impose on these products that were also absent with the Italian product. The introduction of the Italian cisatracurium represented a risk in that it could be confused with other products that are packaged in glass ampules. Health Canada issued a risk communication to healthcare professionals to identify the potential for serious harm if this product, the Italian Cisatricurium, was administered in error due to look-alike confusion with other injectable medications available in ampules. And over the next few slides, I'll share some examples of look-alike labels and packages. And I just want to add the caveat that some of these images may not represent the product as it is currently marketed. Look-alike confusion can also occur between dosage forms. The product monograph provides a description of the dosage form, but it is not an element that is formally reviewed by Health Canada. We may identify concerns prior to product approval, but sometimes, again, it is end users who alert us to a safety issue. In the case on the left, oral venlafaxine was originally marketed with markings that didn't match the strengths, which is not really an unusual situation. However, the capsules of the 150 milligram strength were marked with a 75, as you see in the image, which patients then confused with the 75 milligram capsule and took double the dose. The product is now marketed with markings that correspond exactly to the strength. On the far right, at one point, the manufacturer of Tridural removed the tablet markings from all three strengths, which was identified as a risk for confusion, given that the tablets were a similar size, shape, and color. The markings were later reinstated. Recently, we received a complaint about look-alike tablets between isoniazid and pyrazinamide, which you see on the lower right. These are difficult to distinguish, especially in a compliance pack. And I'm sure you can't tell actually from this image which is which, but isoniazid is on the right. The manufacturer has confirmed that they have added the marking INH to the isoniazid tablets, and we did not request further changes. For injectable medications provided in vials and ampules, there are limited shapes and sizes available. In addition, text on the labels may be small, and there may not be space for distinctive graphic elements. Cap color is identified in reports as a factor that contributes to look-alike errors. However, based on the limited number of colors that can readily be differentiated, it is not feasible to use cap color as a reliable means of distinguishing among the many hundreds of products that might be in inventories. The image on the bottom shows a sample of many similarly sized vials with red caps or ferrules, and this is not an exhaustive sample. On the top left-hand side, we see two vials with look-alike labeling and packaging. Phenylephrine from Marcan and dexmedetomidine from Juno. When the look-alike concern identifies two different manufacturers, we will share the concern with the companies so that they can take it into consideration for future design changes. However, we do not typically mandate a change from the manufacturer when two different manufacturers are implicated. And this is due to a variety of reasons, such as the fact that there is no publicly available repository of labels that allows companies to see across competitors' portfolios, and that creating Canada-only packaging requirements, such as cap color, can result in higher costs for us due to shared supply chains with other markets. Sometimes label changes can also inadvertently result in new look-alike concerns with other products. On this slide, I've also included an image on the right of an EpiPen and the training device, as we have also received reports identifying difficulties in differentiating between products containing active drug and the trainer. The packaging needs to be similar to train the user properly. However, we try to ensure that text such as training device is more prominent than the brand name, and that the brand name is not displayed anywhere on the device without the trainer text in close proximity. And you may be able to see that text training device on the top image just below the black band where the brand name appears. Manufacturers are, however, expected to ensure that there is adequate differentiation within their own product lines. And this is where we request changes if a concern is identified. They need to strike a balance between standardization and differentiation, which allows for the use of a common trade dress within their portfolio while still ensuring there are sufficient elements to help distinguish products. On the far right, we see some look-alike labels from Pendopharm and also from Sandoz underneath, which have been addressed. The two vials actually are hydromorphone on the left and ketamine on the right. We have not talked about color coding, which refers to the use of consistent colors for specific products or strengths across different manufacturers. There are a few examples on the market of this, such as the use of consistent colors for levothyroxine or for warfarin tablets. But in general, we try to avoid color coding on labels, as patient safety research does not support its widespread use. There appear to be benefits in specific practice areas, such as the use of auxiliary labels to color code syringes in anesthesia. However, it is sometimes used in ways that are not ideal, such as the image on the left with epinephrine and phenylephrine pre-filled syringes displaying the same violet color on the syringe outer packaging. This can make it difficult to select the right drug from storage if all drugs in that same class have similar colors. It should be reserved for syringe labels only. Poor label and package design can contribute to look-alike selection errors by making it difficult for end users to identify key safety information. Health Canada, in collaboration with ISMP Canada, has developed evidence-based tools to inform manufacturers on good design principles to apply to drugs and over-the-counter products. These tools are also used by Health Canada when we review drug submissions. And here on the right, I have a list of just some of the elements that we consider, that Health Canada considers when reviewing labeling and packaging. I should also note that organizations such as ISMP Canada have developed many practice recommendations to further address and support the management of look-alike labeling and packaging safety issues. If you have an interest in the topic or have questions around design recommendations, I urge you to take a look at the Good Label and Package Practices guides available on the Health Canada and ISMP Canada websites, and also keep reporting medication errors, as this is the feedback mechanism that drives product improvements. And thank you for your attention.
Thank you very, very much, Sally. Really interesting case of the epinephrine injector, with the similarities between the trainer and the actual device. So you can see how selecting that in error is going to lead to sort of tragic circumstances and tragic consequences in certain cases. And also really interesting comments about color coding, because that is something that comes up quite often. Why don't we color code things? Why don't we advocate for that? You're absolutely right. I don't think the evidence is there. As a general rule, I think there are specific cases where it can be useful and effective. Certainly color to discriminate one product from another, one company from another might be very useful, but within sort of classes of medications, I think a lot of thought and work needs to be done with that. So thanks very much, Sally. And I'd like to build upon what you just heard Um, there's, mainly by highlighting a resource that's available, that's certainly worth exploring. A number of years ago, the WHO released a technical report on look-alike, sound-alike medicines, and there was contributors from around the world, including Canada. It's available on their website. We'll put a link to it on our website when the webinar is available for viewing. And they highlight some of the evidence behind some of the harm of look-alike, sound-alike medicines. And it's somewhat complicated to derive, but it's estimated that look-alike, sound-alike errors are responsible for somewhere between 6 and 15% of all medication incidents. And there are some numbers out of the United Kingdom where about 1 billion prescriptions are issued each year, and the error incidence attributable to look-alike, sound-alike is around 2.2 million. So 2.2 million incidents attributable to look-alike, sound-alike is a very important number, and that's one of the things that we're working hard to prevent. And you've just heard from Sally that the visual appearance of both the outer packaging and labeling, but also the appearance of the actual product itself, can lead to confusion and selection of the wrong drug. So the Canadian perspective you heard is really important, and we're really lucky to have a strong safety infrastructure at Health Canada identifying and mitigating these issues. And I think the WHO work adds to this by highlighting the global work in various income level countries. And it's important to know and address this both as good global citizens, as part of the global healthcare community, but as was mentioned, in times of drug shortages, Canada needs to import medicines manufactured elsewhere that may look different, that may be packaged differently, different concentrations, different expressions of strength. It's on us really to be cognizant of how these external medicines can be differentiated and how we can reduce risks associated with packaging and labeling. So now I'd like to talk a bit about community pharmacy reporting and learning. And as I've mentioned before in this webinar series and elsewhere, most healthcare takes place in the community, in patients' homes, where they manage their own, sometimes very complicated regimens. Patients rely on pharmacists and they rely on pharmacy team members to help them manage this. And because pharmacists are typically the most available, the most accessible healthcare professional. And consequently, there's a lot to learn about safety in the community. And we welcome Ina to explain more about the National Incident Data Repository for community pharmacies. Ina?
Great. Thank you, Mike. It's a pleasure to be here today to share a little bit more about the Community Pharmacy Reporting and Learning Program through the National Snapshot. So next slide here. First, I'd like to share a high-level overview of the Canadian Medication Incident Reporting and Prevention System, or CMIRPS. ISMP Canada is a participating member together with Health Canada, as Sally just mentioned, the Canadian Institute for Health Information, or CIHI as you may know it, Healthcare Excellence Canada, and Patients for Patient Safety Canada. The goal of CMIRPS is to reduce and prevent harmful medication incidents in Canada through the analysis of reports submitted into the 4 different databases that you see here. The National Incident Data Repository for Community Pharmacies is highlighted on the right in yellow, and it is a collection of reported medication incidents submitted anonymously by community pharmacies. Next slide. So community pharmacies began reporting into the NIDR in 2008, and Nova Scotia began submitting province-wide in 2010. In 2025, 15 years later, the 6 provinces of Saskatchewan, Manitoba, New Brunswick, Nova Scotia, PEI, and Newfoundland and Labrador submitted incident reports into the NIDR. I'm pleased to share with you today that as the commitment to reporting and safety for community pharmacies continues to grow in 2026, Alberta began to submit data into the NIDR in February of this year. British Columbia will join in June, which is right around the corner, and Ontario will begin to submit to the NIDR in January of 2027. Next slide. In this slide, we can see the 5-year trend for submission of medication incidence reports, including near misses, to the NIDR. In 2021, the NIDR held more than 275,000 reports from community pharmacies since 2010. For each of the past 5 years, you can see the dark orange bars at the top representing the number of reports submitted in that year. In 2025, pharmacies in the 6 provinces I just mentioned submitted over 27,600 reports into the NIDR, which is 6% higher than in 2024. And at the end of 2025, the NIDR holds more than 375,000 reports anonymously reported from community pharmacies across Canada. Next slide. Here we can see the levels of harm described in medication incidents in medication incident reports submitted in 2025. Non-harm related medication incidents, which includes both near miss reports, those that did not reach the patient, and no harm reports, those which did reach the patient, totaling 97% of the submissions into the NIDR. This would be the total of the light gray section and the dark gray section that you see here on the pie graph. So separating it out, near misses were about 53%, and the proportion of no harm incident reports was about 44%. Harm reports were categorized as mild, moderate, severe harm, or death. And you can see here in the yellow portion that's been pulled out that just over 3% of reports documented mild harm, and notably less than 1% documented moderate or severe harm or death. Next slide. The National Snapshot includes data on who discovered the medication incident. So why do we collect this information and share it in the National Snapshot? Well, if we break down the numbers a little bit, we'll see why this is important information. More than half were discovered by the pharmacist, and this makes sense given that we just saw in the previous slide that 53% of reports were near miss reports that did not leave the pharmacy. This is also helpful to understand in the context of the role of the pharmacy technician as professional scope increases. A key takeaway from this data is that 20% of incidents were discovered by the patient, family, or caregiver. This helps us to understand how important it is that shared learning from the NIDR gets back to patients, families, and caregivers, since they play a significant role in recognizing errors. Next slide. Here we see the top 10 incident types reported to the NIDR in 2025. The proportion of all harm-related medication incidents by type are in blue, and the proportion of all non-harm-related medication incidents are in yellow. So we can see patterns where the proportion of the type of incident for both harm and non-harm are similar, such as for incorrect dose or frequency, which is right at the top. We can also see some clear differences between the types based on harm level. The largest differences are seen for incorrect quantity, which seemingly is less likely to be harmful, and omitted medication dose, which is seemingly more likely to be harmful. Next slide. In this slide, we can see the proportions of all medication incidents reports by the medication system stage involved. Order entry and prescription dispensing were the most frequent medication stages reported. When we take a closer look in a subgroup analysis of the harm-related incidents, the administration stage was 5 times more likely to be reported, where 20% of harm-related reports involved administration versus 4% of all medication incidents. This also makes sense as administration would not occur in a near-miss report. The same subgroup analysis revealed that monitoring and follow-up stage was 4.5 times more likely to be reported in harm-related incidents. Next slide. As a part of our quantitative analysis, we looked at additional information that was included by reporters in their submission to the NIDR. These fields are optional rather than mandatory in most provincial CQI programs. These additional fields can enhance the understanding of what happened, how it happened, and why it happened, as well as supporting the development of safety strategies to prevent recurrence. For example, it's important to look at patient age, as groups such as children and the elderly may be at greater risk to experience harm from medications. Learning about what contributing factors are identified can help those reading safety bulletins and other publications understand if similar vulnerabilities exist in their systems, if similar incidents could occur in their pharmacy. Next slide. Medication incident reporting to the NIDR includes mandatory fields representing the minimum information needed to analyze the incident and share learning. Up until the beginning of 2025, contributing factors was optional in all participating provinces. During 2025, one province made contributing factors and actions at pharmacy level mandatory fields for submission to the NIDR. This increased the data received for those fields by 30% and 6% respectively, supporting improved understanding of what happened and the development of safety strategies to prevent recurrence. As more provinces come on board to the NIDR in 2026, they are including some of these fields as mandatory. Next slide. Here we can dive into the contributing factors a little bit more. Proportions of harm-related incidents are noted in blue, and non-harm-related incidents, including near misses, are noted in yellow. The proportion of harm-related incidents are the largest for the patient education problem category, which prompted the recent provincial NIDR safety brief recommendation to optimize patient engagement at both intake for information gathering and pickup for information sharing. Next slide. In the National Snapshot, we share the top medications involved in incidents reported to the NIDR in 2025. On the left are the medications involved for all medication incidents, including near misses. The prominence of some of these medications may reflect the frequency of prescribing. On the right, you can see medications involved in harm-related medication incidents only. Methadone and levothyroxine remain the medications most commonly reported to be involved in harm-related incidents. Notably, 6 medications in the top 10 list for 2025, so semaglutide, metoprolol, furosemide, ramipril, pregabalin, and duloxetine were not present in the top 10 list for 2024. Next slide. Analysis of reported medication incidents, including near misses, allows for shared learning to inform quality improvement initiatives and development of safety strategies for community pharmacy teams, for other healthcare providers, for patients and families and caregivers, for manufacturers, and for more. Shared learning from ISMP Canada is disseminated in these publications noted on the right, including our safety bulletins, the NIDR provincial safety briefs, consumer newsletters, and today at our MedSafety Exchange. Next slide. These are just a few examples of how data from the National Incident Data Repository from community pharmacies supports shared learning. Thank you for attending today. Back to you, Mike.
Thank you very much, Ina. Really a lot of data to go through that really you can learn a lot from, and very interesting findings. Thanks very much for that. Now, as I mentioned just moments ago, most healthcare takes place in the community, and you've heard about the sort of community infrastructure that's available in reporting and learning. But healthcare facilities are also a pillar of care delivery where clinically and resource-intensive care is performed. And it also includes long-term care homes, which are complex environments in which a great number of medications are delivered to residents. And now I'll ask Dorothy to explain more about the National System for Incident Reporting for Healthcare Facilities. Dorothy?
Great, thank you so much. Good afternoon, everybody. Mike, if you can just transition over to the next slide. The focus of my presentations is really going to be around the transition of the National System for Incident Reporting over to ISP Canada. So let's start with sort of a grounder in what is NSER. So NSER is the National System for Incident Reporting. It's a reporting and learning platform for healthcare facilities. More specifically, NSER was built by the Canadian Institute for Health Information, or CIHI, for hospitals and, as Mike mentioned, for long-term care homes to securely and anonymously share and learn from medication incidents. NSER is comprised of actually two distinct but parallel programs you see in this infographic on the left-hand side. One of the programs is meant for medications, and that was launched by CIHI in 2010, and the other is for radiation treatment, which was launched in 2017. While NSER primarily holds voluntary reports, NSER can also support reporting requirements for hospitals as part of a quality and safety improvement program. Really, the intent is for healthcare facilities to be able to easily analyze their own data, as well as to learn from reports from across the country. Next, thank you, Mike. So you've seen this infographic. Ina shared it in her slides. So I'll be brief about the slides and try and focus it on more of the NSER component. As you can see here, NSER is a key component of CMIRPS, the Canadian Medication Incident Reporting and Prevention System. And if you take a look at the intake and the reporting and learning lines in the top half of the infographic, you can see that NSER is one of the 4 CMIRPS reporting and learning platforms. And you can also see how it captures the ability for healthcare facilities to report into NSER. And you can see sort of that in the broader context of the CMIRPS platform and system. So up until, I guess, from 2010, when CIHI launched NSER, up until March 31st of this year, NSER was managed and operated by CIHI. And really for that, we are very grateful. Over the past year, CIHI and ISP Canada have worked really well together and collaboratively to transition the NSER platform and operational responsibilities over to ISP Canada. And this was completed on April 1st, such that ISP Canada now is responsible for the ongoing operations and management of NSER. And with this transition, we're really excited to be able to continue to offer NSER for healthcare facilities. And with all 4 CMIRPS reporting and learning platforms under management and operations by ISP Canada, we're really fortunate to be in a position to be able to build and strengthen the connections to support improved medication safety across all the sectors. Michael, next slide, please. So NSER is quite unique in that it permits facilities to learn from each other's experiences, while at the same time ensuring all organizations are able to maintain anonymity within the system. Reports can be submitted online or through a batch upload submission process. It really depends on the preferred method by each organization. And I'll touch upon Power BI a little bit, actually on the next slide. But what's also, it's a question that's frequently asked for us, and so I thought I'd touch upon it here. There is no cost to participate in NSER thanks to the ongoing funding by Health Canada. And next slide, please, Michael. So Power BI, NSER is supported by Microsoft Power BI, which, if you're familiar with Power BI, can be a powerful, no pun intended, analytic tool. So I'm going to use what you see on the screen as an example. One can easily navigate Power BI to quickly identify all the reports across the country related to a specific data element. That data element could be, and I'm just pulling some examples here, could be a age group, a particular contributing factor, incidents that occurred on a certain day of the week, degree of harm, or generic drug product. What I did here on this screen is I pulled data for one particular drug product. In this case, it's N-acetylcysteine. And while the actual numerical output from this data extraction has been removed, it literally took seconds to find the reports, and all those reports are de-identified and not attributable to any particular province or facility. But a user can find these reports and review those reports from across the country. And really, the intent is for facilities to be able to analyze their own data, as well as from, as I mentioned earlier, to learn from reports from across the country. And so I want you to pause to think about the possibilities from a quality improvement and medication safety perspective of what can be done. Next slide, please, Michael. So hopefully, if you haven't participated in NSER in the past, I've piqued your interest. And so what does it take to be part of the NSER community? Really, the first step is outlined on the right-hand side of the screen is signing of agreements. There are 3 different types of agreements. The 2 highlighted in blue are the key ones for data submitters. So the first agreement is what we are describing as a letter of understanding. That agreement is at the provincial or territorial level for something like a Ministry of Health, for example. ISP Canada is actively working to have these letter of understanding agreements signed. And in those agreements, it outlines the jurisdictional support for mandate and goals, describes the nature and purpose of shared information. Once that agreement is signed, we're looking at a second level of agreement for data submitters. So this is the data sharing and service agreement. And this is more at the individual facility level, or perhaps the long-term care home level, could be at a corporation level or health authority level. It really depends on who will be submitting the data into NSER and some of that reporting hierarchy. And the last one is a service agreement for data partners. And ISP Canada, for example, was a data partner when CIHI managed and operated NSER. And what this type of agreement permitted us to do is to analyze de-identified data on very specific topics so we could translate the learning from the analysis to actionable strategies. And so that's the agreements. Once the agreements are signed, step 2 is really to register with ISP Canada. So if you were a previous NSER user, you will need to re-register with us at ISP Canada, as we have a new registration system that you see on the left-hand side. That's the user interface. It's a new system supported by Microsoft. Next slide, please, Michael. And I really just want to take the opportunity here to share our appreciation for the leadership teams, the NSER operation teams, and the IT teams at CIHI, not only for the development growth of NSER, but also for the years of management operations. We're very grateful for their support during the transition of NSER over to us and for their continued support through CMIRP. So if there's any CIHI folks on here, thank you. Next slide, please. Okay, so if you're interested in joining the NSER community, please don't hesitate to email the email address noted on this slide. The NSER team is ready to answer your questions. We have a fairly new web page. On that web page right now, we currently share some frequently asked questions, as well as the NSER Privacy Impact Assessment that was completed earlier this year. As we start to grow, as we start to pull in some knowledge translation products, new publications related to NSER, that webpage will be populated. So we are planning for 2 new NSER knowledge products, one for medications and one for RT, and that will be posted on that webpage. With that, I thank you for your time and look forward to hearing from anybody who's interested. And Michael, thank you.
Thank you, Dorothy. Really look forward to the evolution of NSER and the new items and new products that will arise from that. Now, self-assessment helps you and your organization identify what you do well and where vulnerabilities still exist, where some work still needs to be done. And the self-assessments that ISP Canada offers are built upon kind of what you've heard, incident reporting, the literature, other resources. And they're one of the products of a reporting and learning infrastructure that we have in Canada. And they're designed to help you and your organization deliver safer care. So now I welcome Ambika to introduce the 2026 update to the MSSA for hospitals. Ambika, go ahead.
Great, thank you, Mike. So I'll give a quick overview of MSSAs and the recent work we did to update the MSSA for hospital. So the link is available here where you'll get instructions on the information that you need to provide if you'd like to register. ISMP Canada has developed several MSSA programs and medication safety checklists for hospitals and other care settings. And this includes a complementary series that focuses on never events. So these are patient safety incidents that result in serious patient harm or death, yet were preventable using organizational checks and balances. And our focus today is the hospital sector. So the MSSA hospital, it helps evaluate the safety of the medication management system by heightening awareness of the core characteristics of safe systems, identifying opportunities for improvement, creating a baseline measurement of implementation of strategies, and then monitoring progress over time with repeat assessments. And as medication practices, technologies, and safety risks continue to evolve, periodic updates are necessary to ensure the assessment remains relevant, evidence-informed, and aligned with current safety priorities. So at a high level, the key steps in this update were research, ideation and revision, testing, and delivery and dissemination. And here is a brief look at the key sources of information that we reviewed to update the MSSA. And part of that included updating important resources such as the Do Not Use list and the Canadian High Alert medication list. An important change that we made was the scoring of the self-assessment items, and we made them into quantitative definitions because the previous version, we did get feedback that it was too subjective and sometimes difficult to decide between certain scores. So the scoring from 0 to 4 for applicable items is not implemented, rarely, sometimes, often, and always. And for select items with specific criteria, not applicable is allowed, and this reduces the denominator so that the score is not impacted. And for example, if the item is related to care of pediatric patients and your organization never treats children, this item will not present a risk to the organization or the population served, and it will have a not applicable scoring option. But alternatively, use of smart pumps is a recognized safety strategy. So if your organization administers intravenous medications without the benefit of smart pumps, then the patients served are at higher risk of harm related to incorrect or inappropriate infusion rates. And then not applicable would not be a scoring option. So in this scenario, not implemented would actually most appropriately reflect that practice. And these are the updated key elements and core characteristics which reflect parts of and supports for the medication use system. So there were 289 self-assessment items in 2016, and the 2026 update now has 216 items. So we added some new items and streamlined very many of them. And we ultimately want this tool to help hospitals identify opportunities to improve safe practices. And this symbol was marked for 76 of the 216 safety self-assessment items, and that's more than 1/3. And we did mark this in the PDF version, not the online version. And this signals alignment with the recently updated medication management standard from Health Standards Organization, or HSO. And we were very lucky to receive support and guidance from a pan-Canadian advisory panel with expertise in and experience from different healthcare professions and care areas. And a special thank you to the hospital sites that participated in validation testing, and of course our internal team. So I just want to remind everyone back on the first slide, the link and QR code. Please don't hesitate to reach out if you'd like more information on the medication safety self-assessment for hospital. Thanks.
Thanks very much, Ambika. It's an excellent product, and I really encourage the audience to explore our websites for other self-assessments, those of Health Canada, all kinds of terrific resources in all sectors for all disciplines, as you kind of review what we've talked about here today. We and you in the audience, we all contribute to the safe use of medicines, and we all have a responsibility to do our part to improve care. We have a safety infrastructure in Canada. We are lucky to have that, and include the reporting and learning systems you've heard about. We're all in this together to help develop tools to help you in your position as healthcare leaders and as healthcare practitioners. So thanks again to all our presenters for sharing today. Thanks for all your questions, your chat box contributions, and certainly thanks for your time, for spending it with us. Please let us know what you think by completing the feedback poll. We want to hear from you. We learn from your stories. We learn from your conversations about errors. We learn from your perspectives. We want to learn about them from multiple perspectives. So the patient, the practitioner, the system itself. Please think about being a contributor to MedSafety Exchange. Think about something that you've undertaken, some incident you've been involved in, and please help us and help others to learn from that. So please reach out and be a part of this. Again, a link to the recording of this webinar will be available on the MedSafety Exchange website, along with some of the resources we've talked about. The PDF slides is available upon request to that email you see down below. And again, please respond to the feedback poll. We do review it. We are sort of seeking ways to get better, to be responsive to what you need as people out in the field practicing healthcare. And a reminder to keep your calendars open for the World Patient Safety Day edition of MedSafety Exchange in September of 2026. The World Patient Safety Day theme is going to be safe care for non-communicable diseases. So that's a broad topic, and we already have some excellent ideas about content for that. So see you in the fall. And everyone, please enjoy the rest of the day and look after one another. Take care.